very good morning, and I welcome you all to this session on ocular allergy. So from plasty, we are shifting to cornea. Can I please invite my co-instructors to join me on the dais, Dr. Somshila and Dr. Rishi, please.
I'm Rishi. I'm posted at Command Hospital, Lucknow.
So allergic eye disease is something that all of us commonly see in our practice, and it can be tricky to differentiate ocular allergy, the kinds of ocular allergy that we see, how severe it is, how to tailor the management, and the type of allergy that we are dealing with. So the idea behind this course was to make it simplifies as much as possible, to give an overview of all the diseases and then to talk about subsequently the mimickers that we have and the management. So it's a very common disorder affecting up to 20% of the population, affects quality of life, and this is a major cause of absence from school because lots of times it occurs in young kids and they might have other atopic conditions also associated with eye allergies. It often mimics other ocular surface pathologies and it might not be treated adequately lots of times. It can be confused with a lot of disorders. And usually a lot of these patients might require long-term therapy due to their chronic nature. Especially patients who have VKC or AKC might require a long-term therapy. So counseling becomes extremely important and we need to identify the patients and tell them that they will require long-term therapy for these patients. So we will discuss both the typical as well as the atypical presentations, how to differentiate from other disorders, management of allergic eye disease, and also the complications and how to take care of them. I'd like to thank all the speakers for agreeing to be a part of this instruction course. We have Dr. Rishi Sharma, who will begin by talking about overview of allergic eye disease. Then I'll be talking about mimickers of ocular allergy. And Dr. Rajesh Sinha will talk to us about how do we manage these patients, what are the drugs that we currently have available, and which drug to give to what kind of patient and for how long. And then Dr. Somshila Murthy will cover the slightly more complex cases, the complications of allergic eye diseases, and the role of surgery in ocular allergy. So we will start first with the overview of allergic eye disease. I would like to invite Dr. Rishi Sharma for his talk. Thank you so much for being here. And Dr. Alok Sati couldn't make it. He's posted, they are in the army and he's posted elsewhere. So Dr. Rishi Sharma has been kind enough to take this talk for us.
Good morning to you all. I'm Dr. Rishi. I'm from Command Hospital, Lucknow. Ocular eye diseases are basically a group of external ocular conditions, various types because of the hypersensitivity reactions to various kinds of allergens. The basic epidemiology is that 20 to 30% of people suffer from some allergic condition, and out of which around 40 to 60% of these individuals present with ocular symptoms. Why this topic? Puzzled, confused, baffled, unsure, lost, unclear. Variety of conditions, similar symptoms, similar signs, no definitive diagnostic therapies, and a broad kind of management. These are basically the various kinds of hypersensitivity reactions. Just to reinforce the thing, The type 1, the type 2, the type 3 and type 4. The IgE is the type 1 mediated hypersensitivity reaction. These are the various mediators of allergic responses. We suppose the histamine leading to the itching, redness and edema. The platelet activating factor, which again contributes to the redness and edema. The various leukotrienes, the proteases and the eosinophilic chemotactic factors. The type 1 hypersensitivity reaction is leading to VKC, AKC and GPC. The other varieties, of course, beyond the purview of this. And type 4, flictannular keratoconjunctivitis. Again, the confusion, the diagnosis and the treatment. Wine diagnosis, basically the symptomatology and the signs are similar. Traditionally, we classify them as simple allergic, we classify them as perennial, atopic keratoconjunctivitis and vernal keratoconjunctivitis. The hallmark symptom, ocular itching, seasonal allergic conjunctivitis, perennial allergic conjunctivitis, along with vernal and atopic keratoconjunctivitis. Differentiation, severity of itching, the onset, the duration and the clinical signs. The basic clinical features of allergic conjunctivitis, mild itching, it's seasonal in nature. This is just a diagrammatic representation of the histopathological mechanisms involved in the same. Clinical signs, mild conjunctival hyperemia, this glassy appearance of the cornea and the papillary hypertrophy. Perennial allergic conjunctivitis, again, over a prolonged period of time throughout the year. The difference, of course, the duration of symptoms, the signs, the onset. Now, the two conditions which need to be differentiated, of course, the perennial allergic conjunctivitis and vernal keratoconjunctivitis, basically because VKC has more chances of leading long-lasting eye complications. So, on the other side, you can see a perennial allergic conjunctivitis, and on the right side is the vernal keratoconjunctivitis with the giant papillae, the cobblestone appearance as we call them. Again here, the corneal involvement in the form of corneal eruptions, erosions, which can be more seen in the blue filter. Again, we can see there is a shield ulcer developed along with the vascularization, and this is basically a case that I'm going to discuss around a 54 years old male patient, and before that there is a pathognomic feature of VKC, which is a perilimbal pigmentation. This is the supporting literature for the same. What about the atopic keratoconjunctivitis? Again, these are similar forms. The basic difference between the two is that in AKC, the age duration is around 20 to 50 years of age. And when we talk about VKC, generally around 10 to 14 years. History of atopy is always there in AKC. Lower tarsus is commonly involved in AKC, while in VKC, it's the upper tarsus. These are the basic differences. As I earlier said, young, around 8 to 14 years, more preponderance in males. Spring season, while AKC is perennial, equal distribution, chronic duration, and there is punctal stenosis, lower tarsal involved. Epithelial defects, of course, shield ulcer can be there in VKC, in AKC as well. Scarring is generally central, and that's why there are long-term sequelae, visual defects. A 53 years old male patient, a known case of atopic dermatitis since childhood, and along with it bronchial asthma, presented to us with bilateral shield ulcer in both the eyes. There was conjunctival congestion, there is glassy appearance of this, deep vascularization in both the right and the left eye. So we started the patient on topical steroids, low tapering doses of oral steroids, along with lubricants in both the eyes. Around the challenge was basically the treatment because there was no set pattern. These are the, just to summarize, the four pictorial representations of the various conditions. As you can see in seasonal allergic conjunctivitis, the hallmark, of course, itching. There is conjunctival chemosis. Vernal keratoconjunctivitis, we have a shield ulcer, we have a limbal gelatinous nodules, the Horner-Tranta spots, and the superior cobblestone papillae. In atopic, again, you can see there is severe corneal scarring, deep corneal vascularization. And in GPC, though it's not a peculiar kind, not a particular association with the allergic eye disease because it's particularly related to contact lens usage. Thank you so much for the patient hearing. May I now request Dr. Ikeda to continue this session?
Thank you so much for a wonderful talk. Do we have any questions from the audience regarding how to differentiate different kinds of allergic disorders? So, Dr. Rishi, any tips to differentiate between perennial allergic conjunctivitis from mild cases of VKC? Sometimes because VKC patients will also have a waxing waning course, but it might persist throughout the year, whereas perennial allergic conjunctivitis also would be the same. So it can be confusing. So for the benefit of everyone, can you share a few of your tips, what you regularly do in the clinic?
Ma'am, first of all, because the history taking that is important, and as I said, the age group, particular age group, seasonal can be in any age group. Generally, VKC patients will be around 18 to 14 years. Boys, it will have a bilateral involvement in 90% of cases, and of course, the severity will be more than what a perennial allergic conjunctivitis will present with. So these are generally and of course with VKC probably you might like to start with the low dose steroids in the immediate involvement.
Right. Yeah, so another important sign of VKC, of course, we have papillae, which can be present in both. But, sometimes these kids will have this diffuse bulbar pigmentation, which is very, very classical of VKC, and we might not see it as much in perennial allergic conjunctivitis. So when we look at these kids and we look at the conjunctiva, before actually examine them in detail, sometimes that just gives away, it's a clue to say that this patient might have VKC, and that helps in counseling us that they might require long-term therapy, and we need to be very aggressive with these children, especially when we have children with VKC. Another important tip that I would like to share, that sometimes when these patients have papillae, it can be confusing to understand whether they have ongoing activity or whether it is quiet, because the papillae never really completely disappear. So staining really helps. When we stain the ocular surface and we evert and we look at the papillae, if we have that kind of punctate staining pattern, it indicates activity. Any comments from the panelists regarding overview of different allergic diseases and how do we differentiate them? Dr. Somshila, anything you'd like to add?
Just exactly as Professor said, that the eye rubbing and the age of onset in pediatric patients, that would be more I would tend towards thinking of VKC, and adult patients are more likely to have seasonal allergic, just simple allergic conjunctivitis. And the point that you mentioned about as soon as you see the child from the distance, first of all, pediatric patient, and then the diffuse brown pigmentation, so like a muddy conjunctiva. So these are telltale signs for VKC. The reason to differentiate is because PAC or seasonal allergy is a much milder version, whereas VKC can be chronic, and it can also have implications in the patient's school attendance and things like that.
Thank you, ma'am. So now I would like to invite Professor Rajesh Sinha first. We are changing slightly the order of the talks because sir has another commitment elsewhere, and he'll be talking about the various drugs that we have available for different allergic disorders and the medical management essentially of how do we manage these patients.
Thank you, Dr. Ikeda, for the opportunity. And we all handle these allergic eye disease because this is something which is very commonly seen in our clinical practice, and we do encounter these patients, and we all have certain specific way of handling it that might differ. However, I will be presenting about the options and then how I approach a patient of allergic eye disease. So as was very nicely mentioned by Dr. Rishi and Dr. Ikeda, that nearly 20% of general population suffers from allergic eye disease, and most people develop allergies in childhood. However, as was being discussed just now about VKCs and the allergic eye disease, so a large majority is seen in children, but there is a certain group of patients who do have systemic allergies as well, and that they do have these allergic eye disease even in adulthood. And that is why it has been shown that the eye symptoms are the second most common allergic presentation, apart from, of course, the respiratory symptoms. And that is why people who are highly allergic, they do develop these respiratory symptoms, and then they do develop these watering and redness and papillae and allergic eye conditions. So we have to handle them. Of course, the systemic management will be done by the physician, but we have to handle the ocular symptoms, and sometimes we do have to give systemic medication as well for ocular features. So there are many medications. So we have to decide how to select, how to go about, how to make our own protocol so that that fits, and that can differ with different individuals. That can differ in different geographic conditions. That can differ with different, kind of, air conditions, environmental conditions, like in cities where there is more pollution and the cities where there is less pollution. So many factors are involved in managing these cases. So let me just go through a certain group of drugs, and then I will come to the protocol that I follow. So the anti-allergic drugs can be basically grouped into mast cell stabilizers. We have been using it for many years, for decades. The mast cell stabilizers, the cromolyn, glycate, etc. Then topical antihistaminics, we have been using it for a very long period. Even now we have some recent antihistaminics like alcaftadin, and of course the dual acting agent have come up, which not only act as antihistaminics but also act as mast cell stabilizers. So antihistaminics, basically they block the released histamine. So they prevent the itching of the eye, they prevent the itch by blocking the histamine receptors. So once the histamine is released, then they come into action and they block the symptoms. So they are very good to relieve the patient of symptoms, but they basically work on the histamine receptors, and they don't work on prostaglandins and leukotrienes, which are some other inflammatory mediators. Then we also use vasoconstrictors like nafazoline, which is sometimes useful for symptomatic relief. Many times these patients, you have to take care of the allergy, you have to take care of these vessels as well. These vasoconstrictors, they prevent the increase of presence of inflammatory mediators there, like something like nafazoline can be, which has been used for decades now, and which is still useful, which still holds true. Mast cell stabilizers, they stabilize the mast cells, so they prevent the release of histamines. They don't work on the already released histamines, but they prevent the further release of histamines. And the dual acting agents, something like olopatadine, they work on both. They not only stabilize the mast cells, but they also work on the released histamines, and that is why these days you all will agree that olopatadine is something which is most commonly used drug for allergic eye disease, because it not only stabilizes mast cells, it also takes care of the released histamines, and it is available in various concentrations. Initially it started with 0.1%, which was given twice a day, then 0.2%, then 0.7% has come up, and that is given once a day, and that is quite effective. And for obvious reasons, this is a study which has shown comparison of olopatadine versus cromolyn, and they found out that olopatadine is more effective, and that is obvious reason because it has a dual action. So this olopatadine is, of course, the preferred dual acting agent, and it is very effective in all sorts of allergic conjunctivitis, whether it's a VKC or it's a seasonal allergic conjunctivitis or it's a contact lens associated papillary conjunctivitis, and it has been used along with ketorolac. Now why ketorolac? Because ketorolac works on the prostaglandins. Olopatadine works on the histamines. So it takes care of all the inflammatory mediators. If the patient has severe or moderate to severe allergic symptoms, you can use any ketorolac or nepafenac or bromfenac. All these things have been used for taking care of the allergy, because it brings about a multimodal approach, and it covers both histamine as well as prostaglandins. Of course, steroids is the final, we say, brahmastra of everything. When nothing is working in cases of allergies, we have to use steroid. Or some patients who have come with severe allergic symptoms, marked cobblestoning, you invert the papillae, you see the marked giant papillae, you have to use steroid, because it is very essential. It inhibits both cyclooxygenase and lipoxygenase pathways, and it can be used by different routes. It can be used topical, it can be given systemic as well, in short burst for cases who are not responding, and it can be given as supratarsal injection in in conditions wherein there is marked cobblestoning of papillae. Normally, whenever we give steroid, there's a general tendency that we should give high potent steroid so that it works well, and then we can reduce, we can taper off. But in cases of allergies, wherein you may have to use these steroids for a slightly longer period, so in order to prevent the complication related to steroid, we start with a low potency steroid, and if it's not working, then we go to the high potency steroid for a short burst and then come back to the low potency steroids. And as I said, topical steroids, they are very effective in severe allergic symptoms, and but the risk of glaucoma and cataract is there, so you have to be careful in that. As far as I mentioned, that supratarsal injection of steroid is usually very effective. You can use triamcinolone 0.5 ml injection, evert the lid and just go beyond the tarsus, inject at multiple sites, and you may have to inject it multiple times actually in cases of severe cobblestoning. This is still a slightly better one. We have injected, you can see the kind of cobblestoning that was there, but there can be even worse scenario wherein you may have to inject multiple times, 2 to 3 times supratarsal steroid. Only thing is you have to be careful in these patients because already you have used topical steroids, so you will be grossly aware that these patients are not steroid responders, but you still don't know. So when you are giving supratarsal steroid, these patients have to be carefully monitored because this is a depot preparation. It is a depot there and you cannot take it off. That is the thing. So that's why if there is any rise in IOP, then you have to manage it. And you don't have to think about a second injection of topical steroid, second injection of supratarsal steroid. There are certain steroid sparing therapy like cyclosporin and tacrolimus. Cyclosporin is a good immunomodulator which is available in 0.05%, 0.09% and 0.1%. So depending upon the severity, you can use cyclosporin. The biggest advantage is you can start with steroid along with cyclosporin in moderate to severe, and then you can taper off the steroid and continue with cyclosporin because cyclosporin topically given, we had done a long back, we had done a study with 2% cyclosporin in graft rejections, prevention of graft rejection. We found out that the systemic concentration was much below than the concentration that can cause toxicity. So the commercially available drugs are up to 0.1%, so it's not going to cause any problem. And it is very effective immunomodulator. Another immunomodulator is tacrolimus, which is again very useful, 0.03%, 0.1%. And some patients, you can put it inside the eye off label. Some patients, they do not tolerate tacrolimus. So you can put it over the lid also, and there also it works. So that is the advantage of tacrolimus. And of course, tear substitutes are good because they not only wash off the allergens, but they provide symptomatic relief as well. So in summary, if it's a mild case of allergic conjunctivitis, we can manage with a simple dual acting agent like olopatadine and lubricant. A very mild case, occasional allergy, occasional itching, etc., you can just manage with lubricant only. But if there is a significant allergic conjunctivitis, you have to use these olopatadines. If it's a moderate allergic conjunctivitis, you can use a low potency topical steroid for a short duration, taper it off. You can use olopatadine. If it's slightly moderate to severe, you can combine olopatadine with ketorolac or Nevanac or bromfenac with topical cyclosporin and lubricants. Later on, you can take off the topical steroid and continue with olopatadine with topical cyclosporin and lubricants. After some time, you can remove this olopatadine as well because long-term use of olopatadine can also cause dry eye, which can be a complication, which of course will be discussed by Dr. Somshila Murthy. So then you can continue with cyclosporin and lubricants only if the patient is comfortable. So that will not only improve the cause immunomodulation It will also improve the prevent the chance of dry eye. Occasionally, you have to give systemic antihistaminics if it's a severe case of dry eye, severe case of allergic conjunctivitis. So you have to give systemic drugs. And if it's a marked cobblestoning, repeated supratarsal steroid is given. And of course, most important thing is that regular follow-up is essential. For people who are steroid responders, you can use higher concentration of cyclosporin. I have used higher concentration, 2% cyclosporin in some steroid responders prepared in our pharmacy, and it has worked well when used for a long term. So thank you very much once again for giving this opportunity, and any suggestion, any addition to this will be welcome.
Thank you so much, sir, for covering all the different options for management and all the different drugs and how to use it and when to use them. Do we have any questions from the audience? Yes, ma'am, please. Please come to the mic.
Next question, there's another mic also.
Good morning. I would like to know that what is the youngest age when we can start these drugs, like olopatadine and all? Because now I have been seeing in my practice that some kids are coming with itching and all since 2 years, before 2 years, like 1 year of age, 2 years of age. So can we start these drugs safely for them?
We just have to see whether there's a marked papillary conjunctivitis. And if it's not marked, then we can start initially with a lubricant and see whether the child is responding or not. If the child is not responding, then we can use olopatadine in these cases, because we have to take care of allergic conjunctivitis, we have to take care of itching, and we have to prevent the rubbing of eyes, because that can further lead to complications like keratoconus, etc. So that is something that we have to take care. But yes, if it's a mild rubbing, etc., one can start initially with a lubricant, preservative free, and then go ahead along with that. Well, low potency steroid can be used again depending upon the severity. If it's not responding further to, say, you are giving lubricant and olopatadine, then we can use low potency steroid, short burst. But most of these children, usually they develop these allergies at the school going age group. Yeah. So we may start actually because we have to give a long-term therapy. So we should titrate in such a way that we start with the minimum. That is, you start with a lubricant, then we may go ahead with an olopatadine and other things.
Thank you so much.
Yeah.
Sir, olopatadine 0.7%. Is it safe in 5-year childs or?
Yes, it is safe in children as well. That's not an issue. Only thing is, the immunomodulators have not been studied in children. So immunomodulators like cyclosporin, tacrolimus, there is a question mark on that. But as far as olopatadine is concerned, it is safe.
Yeah, olopatadine is not approved for usage in age below 3 years or 2 years, something like that. So that is what it says. But it also says that the doctor can decide. So it's based on us that we can decide, as Dr. Rajesh is saying, that we can decide and administer the drug to a patient who's as young as 2 years of age, but first after trying lubricants. So this question comes because now parents themselves, they read and they say it is not approved for such a young age. Why are you giving it to my child? So yeah.
Actually, cyclosporin also is not approved below 16 years of age, but at times we have to give cyclosporin even at the age of 8 years, 9 years, 10 years.
Tacrolimus, what age is it?
Again, as I said, immunomodulators have not been approved below 16 years of age, but sometimes what happens that you don't want that much of rubbing, and as I said, off-label. So off-label use, you can do it. You don't want that rubbing, otherwise the patient will end up with keratoconus and all sorts of problems. Yes.
Just one last question, sir.
Yeah.
Sir, what happens many times 2 years children also come with lot of allergic reactions. So like you said, we just start with Olopac or lubricant. Many times they don't respond to that, and whenever low potency steroids are added, like Amsen is what people nowadays, then there are lot of reviews which come, this is not appropriate or this is not done. and still they are not handled. In such cases, what should be done?
I'm in another session.
So
Yes.
I can answer that because I was earlier in my, till recently practicing at LVPI, where patients don't challenge us or anything like that, sorry to say. But now I am temporarily moved to Mumbai, where every patient comes being a Google doctor or a chat GPT doctor. So every patient, especially for their children, they're very, very hesitant to use something that says steroids. So it takes a lot more counseling, and then we explain that the theoretical risk of this drop, you know, getting absorbed systemically, causing some growth retardation for your child. That's what steroid. Imagine lotepred 0.2% or whatever going theoretically into the body and causing growth retardation. That risk is so low as compared to the child chronically rubbing the eye, at least developing cosmetically not good looking brown conjunctiva. That is the minimum problem, getting keratoconus. So that's how I convince those parents, the ones
How
who.
long the therapy should?
It is a chronic. That's the reason why for these patients, the first visit will be like a half an hour, 45 minutes, much to the disgust of my optometrist that room is blocked for some time, because they have to have a buy-in in the therapy. It's going to be, initially when they come, I say this is for years. And it's good if it takes less than that, so that they are ready for it.
So
Yes.
we can continue Olopat or
Not
EOS.
steroids, yeah. I'm not talking about steroids
Yeah,
at all.
yeah.
Steroids,
We
as
can.
you said, is short term, but olopatadine, and usually very soon I shift to tacrolimus,
Okay.
the ointment, yeah.
Okay. Thank you, ma'am.
So now we will move on and talk about mimickers of ocular allergy.
The mic is not very loud.
All right. All right. I hope I'm audible to everyone. So there are a lot of conditions that can actually mimic ocular allergies. So we need to understand what we are really dealing with. Sometimes we will tend to overdiagnose these patients of allergic conjunctivitis, because a lot of these disorders have common symptoms of congestion, chemosis, and watering. Now, if the patient has an allergic eye disease, the predominant symptom remains itching. So that is an important leading question to ask the patient: do your eyes itch? What can be the different conditions that we can confuse them with? Some of the common things that we see in our OPD, the most common group of disorders is conjunctivitis, viral being the most important of all of the conjunctivitis group of disorders. Maybe even toxic conjunctivitis. A lot of times they will be using multiple drugs, especially when we have patients of glaucoma or who have been using medications for a long time. The dry eye group of disorders, most commonly meibomitis and blepharitis, can be confused with allergic eye disease, and a few other diseases like episcleritis or Flick-Tendler conjunctivitis or ocular cicatricial pemphigoid, very, very rarely, although it's easy to distinguish, but it can be a differential diagnosis for AKC with significant amount of scarring. So in next few slides, I'm going to talk about these different disorders and a few key points of how to differentiate. So this is a young 25-year-old woman who presented to us with irritation, foreign body sensation. So here the main complaint is irritation, foreign body sensation, watering, redness when we are dealing with the conjunctivitis case, rather than itching. So you can ask them a leading question: do your eyes itch? Usually it involves one eye and then spreads to the other. A classical question that we can ask is, do your lids stick in the morning? Is there associated stickiness and discharge? And lots of times, even in viral conjunctivitis, we might see this kind of serous discharge in the lower fornix. And there are more of a follicular reaction when we examine the lower tarsal conjunctiva as compared to a papillary reaction. So these are the few key points. They can have associated upper respiratory tract infection as well, but this rhinitis can also be present in patients who have ocular allergy. Then viral conjunctivitis can have few of these typical complications that we don't usually see in allergic group of disorders. They can present with membranes and pseudomembranes. They can be subconjunctival hemorrhages as well, and subepithelial infiltrates. Now in allergic group of disorders, these subepithelial infiltrates are very unlikely. What we normally see would be SPKs. Although in viral conjunctivitis, we can have an overlap of SPKs along with subepithelial infiltrates. Bacterial conjunctivitis is usually very easily distinguishable from an allergic group of disorders. There's significant discharge, significant stickiness of the eyes with membranes. So I'll move on to toxic conjunctivitis, which is another important differential diagnosis. Here the patient would be using some drops for a long time, or there might be some history, something like calotropis, juice falling into the eye, and the congestion here is more in the lower tarsal conjunctiva rather than the upper tarsal conjunctiva. So here the pattern of the congestion is very different, unlike allergic group of disorders where the signs are all more in the upper tarsal conjunctiva. And these patients can also have corneal edema as well as inferior SPKs. Corneal edema is again very unlikely to be associated with an allergic eye disease, but it can happen in patients who have a drug toxicity. The next group of disorders is flick-Tendler conjunctivitis. Again, presence, usually the age group is younger, same as ocular allergy, and it is usually unilateral, unlike ocular allergy, which is usually bilateral. Typically, we see this kind of ulcerated nodule which takes up the fluorescent stain. So this can be confused with limbal papillae. Limbal papillae might take up a few punctate staining if we have Horner-Trantas dots associated with them, but it will not be this kind of a full ulcerated nodule with an epithelial defect overlying what we typically see in flick-Tendler conjunctivitis, and we would usually have only one lesion like this, there won't be multiple. So this is how we can differentiate between the two. Then we have the mebomitis and blepharitis group of disorders that are very frequently confused with ocular allergy, very commonly misdiagnosed. Here most of the patients present more with irritation or burning and watering rather than itching, so it is very important for us to examine the lid margins well. And they can also have a picture like this, complications of lid margin group of disorders, where we have marginal keratitis, which can also very rarely present like this with multiple kind of infiltrates. Again, this can be confused with limbal papillae. So here, looking at the lid margin, examining the lid margin is of utmost importance, and we might have lucid interval in few of these cases as well, and these patients might not take, the stain might not be positive for these kind of cases. We can have, again, superficial punctate keratitis in this group of disorders, might be more inferior as compared to superior and allergic conjunctivitis. And another additional step we can do is looking really at the meibomian glands in the infrared light to establish the diagnosis a little bit better. So I would just like to share a case of a 3-year-old boy here who was being treated as allergic conjunctivitis for a long time. He had these vague symptoms of irritation, itching and watering. And when we examined him, actually what we found that he had pediculosis, and that was the reason why he had all of these symptoms for such a prolonged period of time. So sometimes demodex and pediculosis also can look like ocular allergy. So again, just to reiterate that we have to examine the eyelid margin. We can see the pediculosis very well demonstrated over here, even had in his eyelashes. So this is something we really need to keep in mind and look at the eyelashes very carefully. Then we have the aqueous deficiency dry eye. So here we can see the tear film. As soon as we stain, the key to diagnosis for aqueous deficiency is ocular surface staining. We look at the tear film and the diagnosis becomes very easy for us. And these patients again come with a pricking and burning sensation. They can have intermittent blurring of vision as well. The age group is slightly older as compared to allergic eye disease, and there will be underlying history of autoimmune disorder in a lot of these patients. So we really need to take a good history. We should look for causes of Sjogren's syndrome, and a lot of these patients might have underlying rheumatoid arthritis. If you don't ask a leading question, they might not come up with the history themselves. Another diagnosis could be superior limbic keratoconjunctivitis, because all the signs again here are superior. This is a 65-year-old lady with a thyroid disorder. She's been on medication. Here there's redundancy and thickening of the superior bulbar conjunctiva, which is responsible for these signs and symptoms. And here the filaments might be present in few of these cases, which are again more superior than inferior. And filaments are usually not really seen in allergic group of disorders until and unless the ocular allergy has led to a dry eye, which can also be a complication of allergy itself. A rare differential diagnosis can be floppy eyelid syndrome. This is typically seen in male obese patients. They have a very lax upper eyelid tarsus, which can be easily everted, and when they are sleeping it gets everted, and therefore they have all of this papillary reaction and SPKs that we can see on the ocular surface. It can even correlate with the side on which the patient sleeps, so just looking at the tone of the tarsus helps in establishing diagnosis. A rare disorder to be confused though with allergic group of disorders, typically seen in patients who have a very lax tarsus, but something we can keep in mind. Now, episcleritis is more of a painless congestion. Patients usually don't really have significant itching as a symptom. They might complain of some mild discomfort along with redness. It could be nodular or diffuse. There is usually no papillary reaction. So these are the few points that we can differentiate episcleritis with a recurrent allergic conjunctivitis. Again, the history of recurrence might be present both in episcleritis as well as an allergic conjunctivitis. So again, it becomes important for us to differentiate here. We can ask for systemic history as well if we have a recurrent episcleritis. Rarely, ocular cicatricial pemphigoid can be confused with AKC. Again, it is seen in elderly individuals, though it is not associated with atopic dermatitis, unlike AKC, which can be associated with atopic dermatitis, and these patients have severe dry eye with phoneal foreshortening. So to summarize, first and foremost, on the basis of symptom, the first symptom that we need to look for is itching. If the patient's significantly main complaint is itching, we are probably dealing with a case of ocular allergy. If the main complaint is burning and ocular irritation, we could be looking at dry eye group of disorders. If the patient states that I have a lot of stickiness of my eyelids, a lot of watering and discharge, then we might be looking at conjunctivitis. And so again, the first thing, if the patient has ocular itching and redness, if the patient does not have itching, we should consider alternate diagnosis. Second thing, examining the lid margins if the patient has myomitis or blepharitis, and then looking at the systemic associations. Does the patient have any skin manifestations? Are we looking at a patient with AKC? If the patient is a contact lens user, then we could be looking at giant papillary conjunctivitis, which is more of an irritative kind of a disorder rather than allergic eye disease. Again, these patients can have associated rhinitis, asthma, all of these atopic group of disorders, and that actually helps in making the diagnosis. It tells us, it gives us an indirect evidence that this is a patient with ocular allergy. So very important to ask, especially when we have a child, from the parents, that does this patient have recurrent episodes of rhinitis, or does this patient have asthma, or does he have any skin rashes? Again, VKC is very typical, as has already been summarized. We have this kind of cobblestone appearance, severe seasonal itching, and the diffuse bulbar pigmentation, which is very, very classical of VKC. So in a city like Delhi, sometimes we just get irritative conjunctivitis because of the pollution and the level of AQI that we have here. So this is again, sometimes when the pollution gets worse, we do see commonly this kind of irritative conjunctivitis, which is kind of an allergic reaction. So this is the way we can differentiate between different disorders and helps us in making the diagnosis. Thank you. Thank you.
Thank you, Ikeda, for going through all the mimickers. That's because both ways can happen. One is that you can have patients who have allergy, but we miss it and we think of some other diagnosis. But what we see more frequently is that patients with some other form of chronic ocular or surface inflammation are being treated as allergy. And one more differential diagnosis, though I think you touched upon it, was Demodex blepharitis or blepharokeratoconjunctivitis, where they do have what look like signs which resemble allergy. But the clue would be that they don't have that exactly the eye rubbing which starts on its own. And then, of course, you examine the lids and lashes and you might pick up telltale signs, especially in pediatric patients. So in pediatric patients, we shouldn't assume that it's allergy. And earlier I wasn't so aware and used to miss a lot of patients with Demodex, but the past several years now, that's very much high on our differential diagnosis. So if you look for Demodex, you're very likely to see it in our pediatric patients. Any questions from the talk on mimickers? Yes, please. You could come forward and use the mic. So as you saw, and she's highlighted repeatedly that the history of wanting to rub the eye. So allergic eye disease is all about itching. So the patient should by themselves they have a de novo symptom of wanting to rub the eye. It's not that they're putting in drops and then there's itching. So that's a very important differential and a very telltale symptom that you need to pick up. Yes, doctor.
Sometimes you need to see a lot of unilateral VKs in young age group, especially around 5 to 10 years. So what do you take on this?
Ikeda?
Yeah, so I mean, it can be there can be difference in the symptomatology and the signs also. It can be very very asymmetrical in both the eyes. Usually there might be few signs in the other eye also. It is technically a bilateral disorder. It might be very very mild. There might just be a few papillae in the other eye. It is rare to have completely an unilateral involvement, although it can occur. It can be asymmetrical in nature, but when we follow up these cases, typically after a couple of months, we might see that the other eye is also getting involved. But the treatment, as highlighted, remains the same. We need to treat the eye which is has an active involvement at that point of time, and just be aware and inform the parents and counsel them that the other eye might also have the similar kind of symptoms, and they might need treatment for that in the future as well.
So I want to tell you some interesting, it's really interesting, two stories about unilateral itching. It's not, as Ikeda said, but it's not only unilateral, but it's asymmetrical, very asymmetrical. So there's a very young, one of our patients, a very young child who has habit of thumb sucking. So now the child sucks the right hand thumb and rubs the left eye always, because the right hand is not free to rub the right eye. So there's a unilateral asymmetric, it looks unilateral, but it's asymmetrical. And the child comes to us with keratoconus in the left eye. The right eye really looks normal. And you see there is GPC in the left eye. Because the eye rubbing perpetuates. That's why we ask them, we try our best to tell them to stop eye rubbing. Second example is the reverse now. So the child is going to school and again uses the right hand to write. And so the right hand is not available to rub the right eye. So the writing is going on, the rubbing is going on. So we actually gave the child something to write, and we could actually see the parents displayed that. The other thing is that habit of sleeping inverse, sleeping prone, and the child can sleep with the head in the pillow on one side. So you know that mites and things like that also perpetuate the. So these are all the angles that we need to look at, and then we can try our best to figure out what exactly is the nature. It's not really asymmetrical, I believe. I think it's not really unilateral. It's rather it's asymmetrical.
Second thing, is there any role of seeing long hours of mobiles and aggravating these allergies? Any studies?
We always use this to benefit the parents and the child. So we say yes, that is causing the problem, as you know. So we use that restrictive. I'm guessing maybe a small role, because the same thing that it causes. It's not a direct relationship, as you know, but yeah, there's no harm in trying our best to get them off that digital device, which causes all other myopia, and socially also there are a lot of problems, and yeah. But how will a Gen Z live without their, or Gen X, whichever generation?
Thank you so much. And now I'd like to invite Dr. Somshila, and she will be talking to us about complications of allergic eye disease and how to really manage them, and surgical management, different options that we have in terms of surgical management for ocular allergy. And thank you, ma'am, for sharing those two wonderful cases. I think that's very important for us to look for. We might miss these things if we are not really looking at the patients and, just really observing them before we even see the eye. Thank you.
Thanks, Ikeda. So, how many of us in the audience are actively dealing with patients with allergy? Is there anyone who didn't raise their hand? So you're probably a retina specialist then. And how many of you also see a lot of pediatric patients in the allergy age group? So again, almost all of you. So this talk is perfect for you, because you probably didn't need the earlier talks that much, but my talk is about complications and how do you manage them. I'm just restricting to the surgical management, because Rajesh had covered the medical management earlier, but you're free to ask questions. I'm trying to wind up both the talks in as fast as I can, so that we have some time for discussion. Mine is loaded. Aapke saath hai.
We have time, ma'am. We have a good time for discussion as well as for both the talks.
See, Ikeda, this is what happens when you're very good and you upload your presentations and everything. They don't have it ready. It would have been better if I had got my laptop and correct. So as I mentioned earlier that I was practicing for maybe almost 20 plus years at LV Prasad Institute, and I'm trying to set up a new place in Mumbai. And while setting it up, I realized that the patients that come in Hyderabad are very different, and I used to get bothered by them, but now I'm appreciating how well they used to listen to me compared to patients in Mumbai who are very, very, aware and well-to-do and so on. So we all know that it cannot be overemphasized that allergic eye disease and its associated conditions that go with it and its sequelae and complications and obviously cause severe visual loss. There are two pictures here I have. Next चल नहीं रहा है. So slides वहाँ change नहीं हो रहा.
Can we please check?
Okay, thank you. So the picture at the bottom is a case of atopic atopic keratoconjunctivitis, where these patients have very severe allergy and more frequently highly associated with corneal scar. And the figure at the top is a patient with VKC. So बहुत slow load हो रहा है. So my next slide was about the complications in allergic eye disease. And just to say that the complications in allergic eye disease can be due to the disease itself or it can be due to the treatment. कब load होगा? Next slide. Yeah.
Ma'am, ma'am, it's working this side.
Oh, okay. So keep fast, fine. Yeah. Okay, all right. So complications are divided as it could be due to the disease itself directly, or it could be due to the treatment that we're giving. So you heard Dr. Rajesh mention about the side effects of steroids, but the various complications that occur due to the disease itself is, all of us know about shield ulcer. We also are aware now that the chronic limbal inflammation can cause limbal stem cell dystrophy disease. We can also have secondary infections such as microbial keratitis coming in. And we've discussed about keratoconus, which has a high association with allergy. And many of these conditions can cause ultimately corneal scarring, like post-microbial keratitis, even acute hydropsin keratoconus, and so on. Coming to the non-corneal complications, which are also important to know about, includes sort of a mechanical ptosis because of the GPC, and this is very bothersome, especially cosmetically bothersome also, and functionally bothersome to the patient and parents. Periocular pigmentation we had discussed, and that is also almost like a cosmetic blemish for the child. And the dry eye that can set up due to either the chronic condition and partly sometimes due to a lot of treatment, lot of drugs going on in the eye. And we can have cataract glaucoma, and then if we start the child on or patients on oral steroids or immunomodulator therapy, and then we have to look at the side effects of that therapy as well. So where do we have to resort to surgical intervention? That is really the meat of my presentation today. So when we have shield ulcer, it can be because you have there is a mixed mechanism in the development of shield ulcer. It includes both the mechanical component where the giant papillae keep rubbing the corneal surface, which already has deposits due to the very high eosinophilic cells roaming around in the tear film, and these cells cause complexes with the mucus present on the eye, and they keep on impacting themselves in the area of the ulcer. That's how you have a shield ulcer. In the terms of complications of steroid-related cataract and glaucoma, that is a direct mechanism, just like any other reason why you have. I've already discussed about limbal stem cell deficiency. So the hypothesis that we had forwarded way back when I was doing fellowship, I think, is that the chronic limbal inflammation that you have here affects even the environment present for the limbal stem cells, and then as the inflammation keeps perpetuating, it can directly affect the stem cells itself, and you can have these patients having pannus formation on the cornea, and a very small amount of available clear cornea. In very chronic patients, you might see this kind of clinical picture. And I have another case which I'll show you. And this is a patient with very chronic LSCD, which luckily now has improved. And you just have a small window of clear cornea present in the center. So coming to how do you deal with giant papillary conjunctivitis, this is already covered by Dr. Rajesh. So he talked about where you can give the supratarsal steroid injection. This injection really works wonders, and you can also give an alternate to giving triamcinolone acetonide is also to give methylprednisolone. This is a shorter term acting steroid, and it goes in much more easily than triamcinolone, so you can create a huge balloon like you did over here. And its propensity to raising the intraocular pressure is lower than triamcinolone. But then of course you must be able to measure the intraocular pressures in these children and never give this injection, this depot, if you are not able to if you're not able to monitor them post-operatively, because you can cause quite severe glaucoma. So you have to give, as he mentioned earlier, that more than one injection. Here some of it is just going subconjunctival, that's why it's ballooning up so well, but we're hoping that at least most of it is going in the supratarsal space, where it will last for about 3 to 4 weeks, and it will sort of jumpstart the effect on dampening the allergy. And there's very rapid resolution. So the results are so dramatic that by next day morning itself, you can see that the child is much more comfortable, and slowly that our chronic eye rubbing cycle is broken for the patient. There are many other methods to tackle GPC, some of which are kind of successful, some are not. So started off earlier, earlier papers covered simple excision and cryoablation, but then it's very, very highly associated with recurrence. And the other problem is causing that scarring in the superior conjunctiva. So I would not recommend this method at all. So if you have giant papillae, you can excise them, provided you cover them either with AMG or even with mucous membrane. So of late, the group from SN, Dr. Geeta, when she was there, and others at SN have been talking about using mucous membrane graft, but they're doing it for very chronic recurrent GPC, where despite even excision or using all medication including steroids, there is no resolution, and it chronically erodes the ocular surface, and they have reported very good success, and our group at LVP has also done a few such cases. But what I do in cases with GPC where everything else has been tried and it's so severe is that combine it with supratarsal steroid injection, and if I excise some of the very huge papillae, then I apply AMG either single or multi-layered, and I feel that gives a long-term benefit for these patients. So I'm coming to one of my cases, a 16-year-old, and he had VKC for the past 4-5 years with very severe recurrent episodes, and also he came with multiple episodes of shield ulcer as well as a child. And by age 16, he was unable to perform well in school. He was going to depression also. And for these cobblestone papillae, so we had put him even on oral steroids, but that was not really breaking the cycle for him. So we decided to go ahead and excise the papillae. This was in one of his eyes, which was worse. And our very gentle surgical excision of the huge papillae, some of which we left behind, and put a multi-layered AMG as well as supratarsal steroid injection, and continued with short-term low-dose oral steroids, and of course tacrolimus ointment, which he continues to use now. So he did well, and even at 6 months post-op, he was doing pretty well. Has mild reactivations, but the cornea is okay. And since then, he has completed his engineering studies, and now he recently wrote to me saying that he's even got a job. So that was a good case that we could manage. Coming to shield ulcer, these are more peculiar to AKC and VKC, atopic keratoconjunctivitis and vernal. And for grade 1, so remember, shield ulcer is specific indication where we actually need to use topical steroids, and better to be aggressive. So in shield ulcer, I do tend to use prednisolone, but follow up the patient very carefully. So for grade 1, which is where you have very clean looking base, it has just started, so usually steroids and BCL will work. But when you have the base, which is in the picture, the third picture that you see up there, and the fourth picture, where I mentioned grade 2 to 3 and grade 3. So these kind of cases won't improve just with conservative management. We'll have to go in, excise that plaque. So if you see that plaque under the microscope, it is nothing but it's just sort of impacted mucus in multiple layers. It looks like a sandwich. So for that, nothing will penetrate it. You have to remove it. And the risk of, do I have 5 minutes? The risk of shield ulcers is that it's open, there's an ulcer there, so very prone to secondary infection, like in this 8-year-old girl who had bilateral severe VKC, and she had shield ulcer in the right eye and corneal infiltrates. When we did corneal scrapings, we got gram-positive cocci. Luckily, she responded well to topical antibiotics, but did develop a scar. So we had published about the management and clinical outcomes of patients with shield ulcers. And in our cohort, because we tended to see more severe cases, we saw that whenever we were resorting to surgery for these shield ulcers, the group where we applied an amniotic membrane did better than the group where we did not apply an amniotic membrane. But again, we've seen the severe cases. So I would say for shield ulcers, for very mild cases, topical steroids and BCL. For moderate cases, you do have to excise it and continue with topical steroids and BCL till resolution. And for more severe or that very thick plaque kind of cases, apply an amniotic membrane after excision. And in all the three instances, because most of the time you will have GPC for sure, so in all the three kind of cases, use supratarsal injection of steroids. So we also looked at overall the demographic profile of VKC, especially to look at all sorts of complications. We had about 500 patients here, and we saw that luckily not too many, but 10% developed corneal scars, about 6% had keratoconus, and about 6% and 3% had at cataract and glaucoma each. So the overall percentage-wise, 20% of our patients had complications in a group of 500 patients. One of the very, very challenging complications to deal with is when you have a pediatric patient, as it is, it's VKC, very bad VKC, and then you have keratoconus as well. So here we have to resort to very early collagen cross-linking, because you know that it's going to progress in these cases. Also, these patients can come in with acute eye drops. Can you unlock it or something?
Yeah, I'm just telling them, ma'am, because you have two talks, so they thought that one talk is over. So can we please remove the...
Okay, it's progressing. So here's one patient, young patient, I think 13 years old, with advanced keratoconus in one eye and presented acute eye drops in the other eye. The same presentation. वही है.
Please don't change the presentation, just remove the notification that the time is up and we can continue with the same talk.
Third one. So, this is a 10-year-old girl, and she presented with eye drops in one of the eyes. So, despite doing air injection for this child, there was really no change in the eye drops. So, what we decided is to repeat the air injection, and this time we use C3F8, repeat the gas injection, and luckily, slowly the patient improved. So, this is just a surgical video to show what we did for this child. So, you can see that very large eye drops and made a paracentesis, and just like how in DSEX sometimes we use venting incision, so here we used a carefully placed a venting incision and literally could squeeze out fluid. You see that how the fluid is getting squeezed out from the stroma in more than one side. You have to be very careful because there's just epithelium and then hardly any stroma, and then there's endothelium, the Descemet's membrane. So you can see almost visually that now the edema in the cornea looks less. So we very gently massaged out all the fluid, and then at the end of the case injected C3F8 into the eye and kept it for at least, and it slowly resolved. It slowly resolved after a few weeks, and finally this patient did very well. So this is just to show another technique of doing C3F8 by massaging out the fluid, especially in such huge giant eye drops. So 6 months later there was an anterior stromal scar, and we could fit a contact lens, and she had fairly good 20/50 vision with the contact lens. But nowadays, that was in 2016, so for the past couple of years or more, what we do is, published by my colleague Dr. Sunita Chaurasia, is a modified technique of compression sutures. So compression sutures have been going on for a while. In fact, the earlier presentations was in 2007 or something like that, where they talked about air injection or C3F8 with compression sutures. But with this modified technique of compression sutures, you can literally on table see that the DM gets attached, and there is a very rapid resolution within a week's time. So this picture shows actually within a week's time how the edema has cleared. So that was about acute eye drops in patients with VKC and keratoconus. Coming to limbal stem cell deficiency, I mentioned earlier that it's a chronic limbal inflammation that causes this disease. And we have also published earlier that what could be the putative mechanism in these cases, and what else can we do. So we can, earlier days we would do cultivated limbal epithelial cells, but now routinely if you have patients with VKC and stem cell deficiency, simple limbal epithelial transplant, SLET surgery can be done in these cases. And if we have to do penetrating keratoplasty along with this, then we can do a donut AMG. So we have published all these techniques, and you can maybe read through them, the references I've put down there. So what about glaucoma? Glaucoma, of course, has to be handled very aggressively, and maximum medical therapy, because all of the anti-glaucoma agents also cause ocular surface problems. So, and sometimes you might have to resort to an earlier surgery than an adult cohort, because many of these patients are pediatric. The cataract, the special concerns in cataract is especially, we know we can treat the cataract, but the problem is the keratometry here, and this was one such patient who had advanced VKC with corneal scarring due to limbal stem cell deficiency and had a cataract. And the IOL power, depending, so if we used the K1, K2 from the oculizer readings, so the IOL power was -2, but if we just used the IOL master, the IOL power was 14 diopters. So there's so much variation in the IOL power calculation, so we have to be very astute and decide very carefully which IOL to use. Since we were not planning to operate on the cornea at any time soon, so we used the keratometry that was derived from the corneal topography, and we had a fairly good result for this patient who underwent bilateral cataract surgery. So that's all from my side, Ikeda. I really want to thank Ikeda. She's been conducting this course on allergy since Jaipur AIOS, almost pre-COVID and post-COVID. So this is the 5th or 6th year running. Soon we'll have to celebrate the anniversary of this. We've always had very engaging audience, very interactive audience. Usually a fuller hall than this, but there's a lot of competition today for us. And this is my team at Shantilal Sanghvi Eye Institute and I'm practicing. And I'd like to invite all of you who are coming to Mumbai, please visit this really lovely center which has come up thanks to many people who are aware of what is socially good for the patients. And we'll be happy to take you around this facility. Thank you very much.
Thank you so much, ma'am. We always learn many more things from you and understand what else is new has come up in the last recent years with respect to this topic. Do we have any questions or any comments that any audiences would like to? Yes, please, sir. Please come to the mic.
Good morning. You said about -2 power of the IOL2 plus 14.
Yes.
And then how you titrated and how you managed, because you took a entire reading from the optical biometer, or then mix and match with because this is very unusual, -2 to plus 14.
Yeah, because the optical biometer would just measures the, I don't know why it gave 14. I have to go through that case once again. But the keratometry was a very steep cornea, as you saw in the topography. So that was a true power. The true power from the pentacam is what we used finally for this patient. And we didn't plan a toric lens also for this patient, because we don't know in future we might address the cornea as well as the patient grows up. So we used a non-toric lens, and I think we were left with a residual cylinder of -4 or something like that.
Actual length was also getting affected with any difference?
No, the actual length was not getting affected. It was mainly the keratometry was the problem.
Okay.
Yeah, it was the keratometry. And it also might have been because the surface may have been irregularly, we should have looked at whether we should have repeated the readings multiple times to see if it was a surface irregularity, was a VKC active at the time point. So this is just a demonstration that supposing in a quick, busy clinic, you just do an IOL master and use that one-time reading to plan your surgery instead of repeatedly doing at least 2 or 3, just like how you would plan for a very complex case. We're getting multiple readings. So,
do we have any other comments or questions from the audience? So I think we have finished on time. We got the dice 5 minutes later. Thank you. Thank you so much for being here and interacting with us. It's been a really wonderful session. Wonderful to have all of you. I would like to thank all my co-instructors for being here and sharing their insights on the same. Thank you. We'll conclude the session now. Thank you. 10:20 we were supposed to finish.